Do you get your period a lot earlier than you think you're going to get your period, or do you get it really soon after you get a positive ovulation predictor, or do you just have a ton of spotting before your cycle starts? If you answered yes to any of these questions, you may have a luteal phase defect, which could be contributing to your infertility. So today we're going to talk about signs and symptoms and solutions as well. If you're new to the channel, my name is Jess. I am a certified nurse midwife and advanced registered nurse practitioner, and I'm also an infertility mom going on an IVF journey. I've got frozen embryo transfer scheduled for next month. So if you want to follow me on my journey, or you just want to learn more about infertility, you can like, subscribe, turn on the notification bell, and tune into future videos. To get started, let's first define what the luteal phase is before we can call it a luteal phase defect, and I will talk about why I really don't care for that language as well. The menstrual cycle is divided up into two phases, the follicular phase and the luteal phase. So in the follicular phase, you start your period, your ovaries start developing follicles, one of which will become dominant to create an egg. Once that egg is released, the follicle that it was in then turns into what's called a corpus luteum or a corpus luteum cyst. And then you enter your luteal phase where there's a cat licking my foot right now. That's not part of it. Anyways, once you enter the luteal phase, you are waiting to get pregnant. If you are actively trying to get pregnant, your egg is traveling down your fallopian tube, hopefully meeting up with some sperm and implanting into your uterus. And your corpus luteum's job is to secrete progesterone. At the end of typically 14 days, if an embryo has implanted in your uterus and starts secreting HCG, or pregnancy hormone, also known as human chorionic gonadotropin, then that signals the corpus luteum like, hey, I got to take my job seriously. I got to stick around and make more progesterone because we're pregnant now and I don't want to have any contractions. And then eventually between 8 to 10 weeks, your placenta takes over. That corpus luteum cyst regresses, dissolves, resolves, however you want to word it. And then your placenta makes all of the progesterone that you need for the rest of your pregnancy. Now, when we define a luteal phase defect, a standard luteal phase is about 14 days, or usually is exactly 14 days. With luteal phase defect, the definition is less than or equal to 10 days for the luteal phase. And it boggles me why we don't just call it a shortened luteal phase or a short luteal phase. You know, there are a lot of things in medicine where specifically with pregnancy and female reproduction, we have really derogatory terms like if your cervix is getting too short throughout pregnancy, we call it incompetent cervix. Rude. It's also like when we tell women over 35 they're having a geriatric pregnancy. And to me, calling it a luteal phase defect is like if you told a man with erectile dysfunction, like, oh, you have a penis defect. Your penis is defective. You know, no physician would ever tell a man that he had a penis defect. And so why we think it's acceptable to tell women or to tell women that they have a luteal phase defect is just beyond me. It's a short luteal phase. And for the rest of the video, I'm just going to say shortened luteal phase. So you will notice in my definition, it did not include spotting of any type, but that is usually the #1 symptom that women will come to me with when they think that they have a shortened luteal phase. They'll, you know, be trying to get pregnant for a while, and I'll see them for an infertility consult in my office, and they'll say like, well, I have all of the spotting before my period starts. Do you think that could contribute to me not getting pregnant? And it really, that's the research says no. For the most part, you know, spotting can be common, but I do think that there is a line that needs to be drawn somewhere where spotting is normal versus abnormal. So like on our fertility journey, I have noticed on cycles when I am not pregnant, like sometimes I will have spotting for 6 days before I actually get my period. And it's typically progressive spotting, like it's heavier and heavier. And I would say like there's something up with that. And really that's like our big infertility diagnosis is this, you know, shortened luteal phase or luteal phase defect. You know, I've mentioned before, my husband has, you know, sometimes borderline low sperm counts, but like really that's it. And so I think that it could be causing problems for more women than we realize. But also, you know, most women are when they come to me are tracking their cycles with an app. And a lot of times that app is really based off of like a standard 28-day cycle. And for these women who have shorter luteal phases, like it might not be accurate when it's predicting a fertile window. So unless you're actually checking the day you ovulate and then comparing that to when you get your period, you're not necessarily gonna know if you have a shortened luteal phase. Fortunately, there are treatments out there for a short luteal phase. There is an abundance of research that has shown that prescribing prescribing Clomid can help. Clomid is one of those medications that we use to induce ovulation, and typically it's taken starting day 3 of your menstrual cycle through day 7 of your menstrual cycle. And I have taken Clomid in the past, and I typically find I ovulate way earlier in my cycle on Clomid or on letrozole, which is a similar medication, than if I'm not taking those medications. Like typically for me, if I don't take Clomid or letrozole, I will get a positive ovulation predictor someday between cycle days 19 and 21. Whereas if I am taking Clomid or letrozole, I will get a positive ovulation predictor between like cycle days 11 and 13. So that's a pretty big difference. And so part of how I know that I have a shortened luteal phase is I've gotten positive ovulation predictors and then 9 days later gotten my period. So that is not enough time to get pregnant. It's not enough time for an embryo to implant and really take hold. So obviously that can cause difficulty getting pregnant. In the past, we would use endometrial biopsy, or rather a series of endometrial biopsies, to diagnose a shortened luteal phase. And an endometrial biopsy is a pretty invasive, pretty uncomfortable procedure. It does require a speculum placement. I know some providers do them with a tenaculum or without a tenaculum, which is the barbaric toothed clamp that they put on the cervix. And then they feed a long, skinny plastic tube through the cervix into the uterus and pull back on a plunger to create suction and swirl it around inside the uterine cavity to get a sample of the endometrial tissue, and that is not recommended anymore. So if you have a physician who just is saying like, oh, you know, you have a luteal phase defect, we need to do these series of endometrial biopsies, like that is absolutely not up to date and is not what is currently recommended. So then what's causing the shortened luteal phase is the inadequate amount of progesterone being secreted by the corpus luteum to prevent the menses from starting. It is pretty difficult to determine what an adequate progesterone level is. There isn't like a baseline level that's considered normal after ovulation, aside from like 3 indicates that you ovulated. We like to see 10 to indicate a healthy pregnancy, but really there's not this like level of like, oh, we should be going for this much progesterone in the blood work. And progesterone is secreted in pulses, and it can vary like wildly within a 90-minute time frame. Like it can increase and decrease 8-fold, which is pretty significant. So you never know when you're checking someone's progesterone, are you at the peak or are you at the nadir? But a lot of women will come to me asking for progesterone when they're concerned that they have a shortened luteal phase, and there's absolutely nothing wrong with taking supplemental progesterone. It is not going to hurt anything. And so as a provider, I never say like, oh no, I'm not going to give you that. Like it's literally not going to hurt anything if someone wants to take supplemental progesterone to try and make their luteal phase a little bit longer. And typically the way that's done, what I've done mostly in the past and what I've seen done in practice too, is usually just 200 milligrams of micronized progesterone. It comes in a little capsule that's typically cased in peanut oil, and you just insert that capsule vaginally at bedtime. It does, you know, make things a little bit goopy, a little bit messy, but it's easy to do. It's, you know, not costly at all. However, I do let patients know, like, research doesn't really show that this does a whole lot, but it's not going to hurt anything. If you do get a positive pregnancy test after starting supplemental progesterone, however, you do have to continue to take the progesterone until at least about 10 weeks of pregnancy, where you hit that point in your cycle where you know your placenta is going to be secreting enough progesterone to maintain the pregnancy. You don't want to like artificially cause this like drop in progesterone by stopping your progesterone, which then can cause bleeding. A lot of women will want to check their progesterone if they are pregnant, and if they're not on progesterone supplementation already, I think that's fine. And a lot of times if they do have that level of progesterone that's less than 10, even sometimes less than 25, I'll say like, hey, why don't we just add some supplemental progesterone? Again, it's not going to hurt anything. You know, there isn't this huge benefit shown in the research, but, and I find most women are like, yes, please, I want to do anything that I can. But with a natural cycle, of conception, like typically the research shows no benefit to the added progesterone. And then I think something important to note too is that repeating a serum level progesterone after someone has started progesterone isn't going to be helpful, because the progesterone action is so localized to that area of the body. You are not going to see a serum rise in progesterone in the blood level. So if you test someone's progesterone, it's low, and then you start them on progesterone, repeating that blood work later is not going to be useful to you at all. So I recently went to a continuing medical education event hosted by the University of Washington, and it was actually hosted by a certified nurse midwife who just does infertility work, and it's just so great to see these events hosted by midwives. We need more of that in the world. But what she had mentioned was that the dosing now for supplemental progesterone, it needs to actually be 200 milligrams of that micronized progesterone twice daily. So inserting a capsule into the vagina in the morning and once in the evening at bedtime. And so that's actually a practice change for me. I had always just done once daily, but since going to that event, we'll do twice daily dosing from now on in the future. Where the research does show a benefit with supplemental progesterone is with recurrent pregnancy loss, and specifically with 3 consecutive pregnancy losses. There is some debate in the medical community right now over what constitutes recurrent pregnancy loss, and I actually went to a conference hosted by Seattle Reproductive Medicine a couple of years ago. I think it was 2 years ago now, where they said actually if you've had 2 consecutive pregnancy losses or even just 2 pregnancy losses where the pregnancy was confirmed with ultrasound, like that's not normal, and they consider that recurrent pregnancy loss. And again, for me as a provider, like it just doesn't make sense. Why would I tell a woman like, oh, well, you've only had 2 pregnancy losses, you need to have a 3rd one for this to have any benefit, so I'm not going to give you this drug that has no downsides this time around. Like, no, that's ridiculous. I'm not going to tell someone they have to have a 3rd miscarriage before I'm going to give them progesterone, because again, there's no harm in progesterone. It is not going to hurt anything, and if there's any chance that it might help their pregnancy, why not give it? Why not take it? So current research does not really support luteal phase defect as a singular cause of infertility, which I personally find frustrating because I do feel like it's our, mostly singular cause of infertility. I mean, we do have a little bit of male factor, but really, like, I don't have endometriosis, I don't have PCOS. Like, we've done all of the testing of could I have, any of these other bleeding disorders or genetic disorders, and everything has come back normal. Like, this is the one thing that has made it super difficult for us. And so I really think more research needs to be done. And I found it kind of frustrating. I went on Google Scholar and just typed in luteal phase defect infertility just to see what was out there. And the majority of the articles I found were published between 1980 and 1996. So really old data. All of the articles I saw that were posted in the early 2000s had titles like luteal phase defect, is it a myth? Or just things alluding to it's no longer a concern. And I just really don't think that's fair. And I think this is another one of those instances in medicine where it's something that only affects women. I don't know who's going to benefit from more luteal phase defect research if we feel like we've got solutions with Clomid and with letrozole and with progesterone. And I will say some of the research that was out there, a lot of it was focused on luteal phase defect and endometriosis, or the benefits of Clomid for luteal phase defect, which I mentioned research does show that Clomid can be helpful. And so I don't know who is really feeling like they're going to profit from a luteal phase defect study. Who's going to fund it? It's unfortunate because it's definitely, like, you can't tell me that 6 days of spotting before someone's period starts is normal. I don't buy it. I think I mentioned in my last video, we do have an embryo transfer date set. It's going to be October 5th, so I'm actually flying down to Phoenix in a couple of days just to get a baseline ultrasound. And I will mention, if I had realized how often I was going to have to fly to Phoenix to do IVF out of state, I'm not sure that I would have done it. I was thinking it would be like maximum three visits, and so far this is visit number 4. Obviously at least 1 more for embryo transfer, and even more if embryo transfer is not successful. So if I had a do-over, would I do it in Phoenix? I don't know. I'll probably make a video about that at some point. And other exciting news, we got kittens. They have been a little beacon of light the last few days while we've been going through infertility. So if you want to learn more about infertility, if you have topics you'd like to learn about, please mention them in the comments. I do plan on doing videos on PCOS and low sperm count, and then of course more IVF videos. So if you found this video helpful, please thumbs up, subscribe, turn on the notification bell, and I will see you guys in the next one.